right. It's initiating the stream. There we go. Let me just confirm on Facebook. Okie doke, we are live. We are there. And, people joining the room fast. A lot of people from YouTube, which we love to see, but let's not keep them waiting any longer. Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and Neuroendocrine Cancer Foundation program. My name is Rain Bennett. I am your host this episode and every episode. I am a filmmaker and a writer by trade, and I've been working alongside the NET community it is almost 2026, folks. That's kind of wild to believe. I think I started working with CCF in 2011, 2012. So 13 years, 14 years, I have lost count. And in that span of time, in that decade plus, I've also lost count of how many videos that we've created, Q&A sessions like the one you'll watch today, patient-centric documentaries, treatment-based videos, all kinds of videos, but with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do. Now, if you're new to this journey or new to the show, I want to say welcome. And the value of this show specifically, as I see it, is one, absolutely the information and answers to some of your questions that you will get from our guest presenter. But secondly, the shared stories, the shared experiences from within the community, the folks there in the comments section. And you can see that some of them are already signing on and saying where they are signing on from. I always ask to do that because I love to see how far the program reaches. And it surprises me every week that we have people from all across the world tuning in live, not just the replay. So if you're new to this journey, I want to say the power of this community is like nothing I've ever seen before. So embrace it. They will embrace you back. And so often I see patients getting guidance for their journeys from the journeys and the experiences of other patients, of other support group leaders, caregivers, etc., in the space. So I just want to say that it's a really beautiful thing to watch. So say hello, tell us where you're signing on from before we start the show. And I am excited today because we have a first-time guest, which doesn't happen too often anymore. And I'm excited to welcome to the show Dr. Junaid Arshad. Dr. Arshad, how are you today, my friend?
Thank you very much, Rain, for having me. And thank you very much for all of our listeners who have taken time out of their busy schedule and join us today, to listen to us today and share their questions and stories with us. I'm doing very well, joining from the heart of Sonoran Desert from University of Arizona Cancer Center, Tucson.
So tell us what, speaking of that community I alluded to, tell us what you do over there in Tucson, what role you fill in the overall NET community.
So I am a medical oncologist. I focus on GI cancers, primarily upper GI cancers like gastroesophageal cancers, and an expert in neuroendocrine tumors. I'm primarily based here in Tucson, working with University of Arizona Cancer Center. We have an NCI designated cancer center, and we have set up a specialized clinical and research program that focuses on the treatment as well as development of novel drugs in the treatment of neuroendocrine tumors over here.
Got it. And what percentage, if you could put a number to it, of your patients are NET patients?
I think there are quite a few patients over here. I would say that 60 to 70% of our patients are neuroendocrine tumor patients, and which goes along well with what that's been traditionally labeled as being rare. Relatively uncommon. I don't like to use the word rare anymore because we have a lot of patients, and this is how it happens. When we started the program, we've been clearly defying this notion that the neuroendocrine tumors are rare.
Yeah, that's a good point. Also, I'm curious. I always like to ask this question: how did you end up in the NET space specifically? Was there a mentor that you kind of followed into that space, or it's not? I don't want to use the word rare either, but it's always interesting to me the paths that lead people to this space.
I think I don't think I've ever been asked that much that how I joined the neuroendocrine tumor, this field. I trained as I always wanted to be an upper GI oncologist. I trained at University of Miami, and it wasn't until I graduated my fellowship I took my first job and I didn't see any patient in my fellowship, any neuroendocrine tumor patient, which was surprising. It was until my first patient I saw when I was actually starting my first job, and I had to read and help that patient navigate this journey of neuroendocrine tumor care. I was thrilled to know and read a lot about neuroendocrine tumors, and in an attempt to help that patient, I reached out to some of the experts, tried to find treatments for that patient, and that got me really interested into this field that I decided that, and there weren't that many experts, and the treatments, they weren't available in every single community settings. So that just led me to this passion that, hey, I want to be that person. I want to be the one helping out these neuroendocrine tumor patients. There is an area of unmet need. We need a lot more people. And these, while people keep labeling these rare, there are patients that need help. And I want to join that force to help these patients. So this is how I got into this, and then
Mm.
started reaching out to people, and very, very grateful for all the mentorship. Met a lot of great mentors and people who helped me develop expertise in the last 5 years in this disease field.
Awesome. Thank you for sharing that. I appreciate that. Folks, it's a few more announcements or kind of best practices before we get started. Go ahead and start sending in your questions because they inevitably start piling up and we move as quickly as we can to try to get to them all. And we often don't, but hey, that's what keeps the show going. But go ahead and start sending them in now. A few best practices for you in this format, virtual format, especially if you're not Dr. Arshad's patient. It's really hard to answer super case specific, super dense questions. So try to formulate your questions in small generic chunks. There's no limit to how many questions you can ask, of course, so you can always ask follow-up questions to that. So think about it like a trail of breadcrumbs. Like, what's the first question you need to get answered that leads you to the next one? It's just easier for us to field it in that way. And if Dr. Arshad needs some clarification or a little bit more context, he'll ask for it. And then, of course, you can chime back in, but that just helps us, keep the show moving along. And one of the things that NCF team does on the back end is if Dr. Arshad or anyone else mentions certain resources or things like that, we will try to add it in the comment section, add the links in the comment section, so you don't have to like try to jot notes down or open up a web browser and try to find what we were just talking about. We'll try to add that for you. One announcement I wanted to say before we get started is, I mentioned at the top of the program, we work on various types of video content for CCF and NCF, and one of them is the documentaries that we produce. We just had one come out a couple of weeks ago with Ilka and Shane Peters about caregiving and community, the family involved with this, and we're working on a bigger piece right now. And I was fortunate enough over the past few days on the West Coast to spend some time with the NCF team with Mary and Kavya and Lisa and Heather, and I know some of them are in attendance. And I gotta say that I have known these ladies for a long time and worked with them, but never met them all in the same place. And they are all so incredible. And I had such a good time with them and we got such good content, but it just shows me, and I talk about it every week, but it reinforces the fact of like the power of this community, seeing them all come from different backgrounds and all sharing the same passion about this disease and helping me so much to tell the story. I just want to send all my gratitude and thanks to the NCF team. I've known the strength of that team for years at this point, but I got to really see it firsthand over this week. And I just want to say that I appreciate you all and I'm grateful for you. Okay, that's enough about me and what we're doing. Let's get into the show. I got a little shout out back though. That's nice to see. So there's a lot of activity, Dr. Arshad, going on right now. As I said, I've been in the space for 13 years. So I've seen a lot of transformation and growth and developments myself since starting working with this disease. But lately it seems like there's been a flurry of activity, a lot of exciting things going on right now. What are some of the developments that are currently happening that you're most excited about?
I think this is a very exciting question, and I think this is absolutely the appropriate time to ask this question too. So, we are finally reaching this point. There is an explosion of new therapeutics that have started to come into the world of neuroendocrine tumors, both the well-differentiated part and the poorly differentiated, which we call as the neuroendocrine carcinomas. So there are several new drugs that have been in the pipeline, for testing in the neuroendocrine tumor, just like when we start developing drugs, we start with phase one, we test in several different subtype of tumors. And now, initially, neuroendocrine tumors were subconsciously or with a misunderstanding were missed and were not included in that basket of tumors where we wanted to test the new drugs. But that is not the case anymore. We have been all these novel drugs, which are called antibody drug conjugates, kind of like a fancy word for it, but these are really state of the art new medications. They have all been tested for safety in the neuroendocrine tumors too. So in addition to what we already have before, now neuroendocrine tumors are formally being accepted to test these new medications. In addition to this, that testing new medications, we have a lot of clinical trials, which are called major landmark clinical trials, who are testing the sequencing of these It's not just about developing new drugs. We want to sequence them too. We want to compare them to the existing treatments too, to give us an answer which treatment works the best or which treatment works better as compared to the other one. So that is an important question in translating, in moving the field forward. In addition to this, we have developed as a community, we have grown as a community. Here we are sitting talking about, neuroendocrine tumors over here. I think that is a growth in itself. People have started to realize, people have started to come together, join hands together. So I think all of this is very exciting.
That's a good point. I like that last point. Okay, so flip side of that question, what are the gaps that are still there, or challenges that you face that you would like to see addressed, and more attention and activity and funding go towards in the next 5 years?
Absolutely. So, it's relating to my last point that we may have been lagging a little bit in this race of curing the cancer. We may be behind, but we're still in the race. We're still running, and we're going to catch up. But in order to catch up is this gap, and some of these gaps are related to development of scientific gaps, like development of biomarkers. We are still short of having a designated biomarker which we can use to treat patients or decide which treatments work better than the others, or can use for diagnosis or determining prognosis. Meaning how long someone will live if this biomarker is positive or negative. So that is one of the most basic gap in the scientific knowledge. So there is a lot of work that is in progress to bridge this gap. We have several new targets that we are under consideration for these biomarkers. And once we find a special target, soon we will also know that we will have a medication that will be able to target that biomarker. In addition to the scientific gaps, gaps in the community, still there are some areas in the country where, there is not good access to these novel treatments, like radioligand treatments, like Lutathera. Some of those are like state-of-the-art treatments. So there are gaps in bridging the access to care for these patients and getting connected with those patients whom we are not able to reach on an everyday. And then comes the question of the funding too. We want to make sure that there are enough resources that are available, resources for access, resources for research development. So I think some of those gaps are like present, but we're effectively or working every day to bridge those gaps.
Got it. Thank you. Okay, let's start taking some questions from the audience. First question comes from George, and it says explained ill-defined PNET. I'm not sure if he means poorly differentiated. But he was diagnosed with a PNET and said explained ill-defined. Do you think that's poorly differentiated, Dr. Arshad?
I just some clarification would be nice, but what it infers to, I think, is sometimes the scan just puts an ill-defined. So maybe it is George is referring to that the boundaries of the tumor are not clear on the imaging, but certainly, I mean, if you have some clarification that you normally don't use the term ill-defined to describe poorly differentiated, but ill-defined usually means when you can't see the boundaries of the neuroendocrine tumor on the scan.
Got it. Okay. So yeah, I wasn't familiar with the term ill-defined either, so I made an assumption there. So what problem does that present then if that's the result on the scan?
I think a lot of this depends on the imaging modality,
Mm,
Brain, that sometimes we use CT scans because MRIs may not be as accessible. There may be financial reasons or timely access to the imaging modality. So we CT scans are one of the recommended imaging modalities. So if you just do a CT scan, let's say without contrast or a single phase contrast. That's also some of the point I will clarify over here, that single phase contrast CTs, they are not sometimes able to pick the tumors on this, or a poor quality CT scan may not be able to show that. But if for some reason that happens, we can always choose another modality, like we can choose an MRI with and without contrast to help us better see the boundaries of the actual tumor, and then which later impacts, if we are worried about like the surgical treatment or actually determining whether a certain treatment is working or not working.
mhm. Got it. Thanks, George, for your question. Let me know if I did make the wrong assumption there. If you have any clarification, let us know. And of course, if you have any other questions, send those along. Wasim says, I agree with the biomarkers, the point you had made earlier. Having scans all the time is not feasible for patients. Um, sorry, Lila, you were about to say something.
No, I think I was just kind of like,
No,
um,
just
yeah.
nodding your head with that. Can you talk a little bit more about the importance of biomarkers?
So absolutely, I think the biomarkers are like the core of the modern day oncology care. Biomarkers are special genetic alterations or certain molecules that we can find in the gene of the tumors that we can that we can test to either identify or diagnose cancers, or we can use them to make treatment related decisions, or we can just trend them or follow them to see if the cancer has responded well to the treatment, let's say after surgery, and then we can follow them serially to see if the biomarker levels are going up as the cancer reoccurred. So biomarkers serve several purposes. And as we are moving from this traditional chemotherapy related treatments in oncology, we are trying to develop more focused treatments. Now, more focused treatments like certain patients who would benefit more from these treatment options. So, this is why the biomarkers are important. This is why one of the reasons we have some revolutionized the treatment of some of the other cancers like breast cancers. We have colorectal cancers. There's a lot more work that needs to be done, but we have started, and lung cancers too, and we've started to see how these patients have started to live longer. So I think the biomarkers are really important. They can help us with the diagnosis when the scans are not available. They can help us make treatment decisions, meaning it's not one size fit for all. Patients with certain biomarkers will benefit more from one treatment than the other, and they can certainly help us to detect recurrence too.
Got it. Thank you so much. George, with the ill-defined PNET, chimed back in and said, yes, it was the result of the PET scan. So then the original question is, I don't know if you had anything else to expand on, can you explain ill-defined PNET in terms of the PET scan results?
So I think PET scans are good for making initially the treatment, initially when we're diagnosing and formulating the treatment plan. Usually the PET scan should not be used to monitor the disease. It's unclear still a little bit that if this PET scan was performed initially or for monitoring the treatment response. But if for some reason the PET delta scan does not show a specific type of tumor, the next step is to consider like an MRI or a dual phase CT scan to see actually the presence of the pancreatic neuroendocrine tumor.
Got it. Thank you. And thanks, George, for chiming back in. Let me know if you have any other questions. Folks, if you joined us a little bit late, this is Luncheon with the Experts, a program brought to you by CCF and NCF. We are here with Dr. Junaid Arshad. Great questions so far. Keep them coming. We're going to keep plugging along. I have a comment from Teresa. From NC, seems medical centers are clueless about NETs and pancreatic cyst. I don't want to speak out of turn, Teresa. I am not a medical expert. However, just recently, a couple weeks ago, we had Dr. Diane Reedy Lagunas on the show, who is now working at the program here at Duke. I live in Durham, North Carolina. And so I do know that Duke has a pretty good program there, that it existed even before she came. Again, this is not my specialty, so somebody at NCF might be able to chime in better to help you. But there are people in North Carolina that are well educated and experienced with NETs. At least I know at Duke Medical Center. And that's a good point I want to bring up too, folks. In between the shows, if you need help, if you need answers to your questions, we have a support line over at ncf.net/support line. So this is the perfect avenue or perfect place to send questions like that, or questions that you just don't get answered. It's a good line to have, that we have consistently open between the shows. You can always come back to the show, but we do the show every 2 weeks. So sometimes you need to get an answer sooner than that, and NCF will do everything that they can to get you that answer. So thanks, Teresa, from over on YouTube, for joining us. Let me know if you have any questions. And that episode with Dr. Diane Reedy was just a few weeks ago, and you can always see our previous episodes on the YouTube channel. There's a playlist for Luncheon with the Experts, and you can see them there. By the way, if folks, if you're here and you see someone that is normally here, or you don't see someone rather that is typically here and is not, go ahead and share the program with them, tag them in the comments on Facebook, let them know that we're going live today, and get them in the room. Okay, next question comes from Lori. Lori says, does PRRT damage the kidneys?
So the answer to this is one of the documented side effects of the PRRT, which is peptide receptor radionuclide, and in this case we use Lutathera. So this is one of the known side effects of lutetium dotatate or Lutathera treatment, which we have known in the NETTER-1 and NETTER-2 studies. But when we are giving the treatment, we do include this renal protective agent, or it's called an amino acid infusion. After patients who receive the Lutathera treatment, they do get an amino acid infusion, which is used to protect the kidneys. Now, again, the theme of my discussion today is that nothing is a one size fit for all, and it's all multidisciplinary care. There's a lot of other factors that go into damaging the kidney. How is the kidney function to begin with? Does the patient have other medical problems which can affect the kidneys, like diabetes, high blood pressure, heart disease? Are the patients taking any medications which can affect the kidneys? Are the patient able to drink enough water, able to maintain hydration? So all these factors, they do play a role. And of course, it depends on the tumor burden too. So there are tumor factors, there are patient factors. All these things play a role. And when we're making decisions like this is important that we involve colleagues like our nuclear medicine, radiation oncologists, to make that decision if this treatment is likely going to damage the kidneys or not.
Got it. Thank you. Thanks, Lori, for your question. Next question, still in the PRRT space, from Mara. Mara says, can chromogranin A during PRRT give false results?
So chromogranin has been one of the first biomarkers, an example of the biomarkers we've had in the field of neuroendocrine tumors. I personally don't, it may have been the first, but it's not a very reliable biomarker. So my personal opinion is I'm really skeptical about the use of biomarkers. I always say this, a single value of any biomarker does not really help you much. It is the trend that helps you. And while people are on PRRT treatment, this is a radioligand treatment. It has a slow mechanism of action, and sometimes when the tumor response is underway with lutetium dotatate, some of the chromogranin results can be very misleading. But again, it depends on, the patient factors. Does they have chromogranin levels are also affected by the kidney function, by creatinine. It depends on if the patient has any other problems or on the disease burden. A number of factors go into this. But to answer simply this question, chromogranin A levels during the PRRT treatment are not very reliable.
Got it. Thank you, Mara. Actually, still in that space, Lady RNT from YouTube says, my endocrinologist and I believe I have a net in the small bowel, but chromogranin A wasn't positive. So how do we find it? Insurance won't pay for the octreotide scan that he ordered.
I think the octrio scans, if they're referring to a little bit of clarification, the octreotide scans, or like they call like the octreotide scans before,
Hmm.
um, they're not commonly used these days anymore. The PET dotatate scans are the newer alternative and the more standard of care that we use to determine where the tumors are located. A lot of times we don't see chromogranin levels. Not all tumors secrete chromogranins for several reasons. Because of biology, they may be inactive, maybe very slow growing, or maybe they're just non-secretors. So sometimes not having chromogranin A does not completely rule out having a neuroendocrine tumor. And having a PET dotatate scan, is a state of the art scan that we have and we use for diagnosis. Not so much the octreotide scan anymore. But like I said, it can be a discussion with the insurance companies where your provider can talk to them, trying to explain this situation. Because going back to my first point too, it's not a one size fit for all.
Got it. Thank you. And thanks for your question. Next question comes from our friend Sasheen. Hey, Sasheen. Excuse me. Does location of primary SI net make a difference in developing complications? The pathology was described as unifocal net, as jejunum and ileum. A week later, developed anastomosis, a suture site with formation of abscess and small bowel leakage. Healing from that emergency lap, only to develop yet another abdominal infection and abscess without any signs of a leak. I'm still shell shocked at how this all went down, and surgeon is very experienced with nets. Most SI nets seem to be in the terminal ileum, and I don't read much about extreme complications. Let me know if you want to repeat any of that or if you followed along.
I think the question is related to the complications that may or can
Correct.
happen
Yeah.
with after surgical treatment of neuroendocrine tumors, especially coming from the small bowel origin. I think this is what the question was, right?
Yes, I believe so. And Sasheen, you let me know if not.
So absolutely, I mean, complications can happen with anything. There are risks and side effects to almost anything. I always say that you read the side effects of aspirin, and then after you read them, you may not want to ever take aspirin again.
Hmm.
Um, so there are risks and side effects to everything, and none of that reflects just on the surgeon or anything. That sometimes things happen even though everything was done correctly. So these tumors in small intestine, like jejunum or ileum, they can pose a risk of obstruction. This is one of the reasons to operate on them, and surely infection. This is an area where there is a lot of bacteria, and sometimes the infections can take place, even though you have taken strict surgical precautions. And infections and abscesses can still happen, which are some of the listed and proven side effects for surgery too. And so the best way to deal with this is, follow up with your providers too. It may seem like a setback that has happened and it's quite unfortunate, but there are several ways to treat those infections and abscesses as well. And I wish you, well, that, you follow up with your providers and hopefully you'll be able to control the infection.
Got it. Thank you, Sasheen. Let me know if you have any other questions. Next comes from Shay Marie over on YouTube. Hello, grade 2, well differentiated neuroendocrine here. Primary site ovary, but metastases to lymph nodes too, and peritoneum and rib. Do you approach treatment for young people differently than elderly?
So absolutely. So, going back to that multidisciplinary, not one size fit for all, cannot say this enough that each decision of the patient goes into I mean, each piece's information goes into making the final decision. So the patient's age is important too. There are certain treatments we cannot give to older patients. And while we are, talking about lutetium dotatate, we do want to see that a younger patient like this has a whole life in front of him to live, and we do want to take into account the long-term complications of certain treatments like Lutathera. So we do take into account, whereas the treatment modalities may be the same, but we do want to plan for a longer duration for a younger patient and want to take into account how this will impact their quality of life. How will this impact, their work life or their study life or other family members as well. So we want to take into account all of this. This is again a multidisciplinary decision.
Speaking of multidisciplinary teams and such, I know some of the people on your team are in attendance today, and I wondered if you could talk a little bit about, we touched on the beginning of the program, the aspect of the strength of this net community, but specifically through the lens of how does it help you do your job more effectively with this disease specifically, having this community, this smaller community around you, your mentees, the people, you were listing off to me even before we started recording all the people that were there. And I know that that's not uncommon, like to have a diversified team like that. Why is that so important to you, in your work with this disease specifically?
I think this is why I we were talking about this, that an effective team is the key to leading like a successful team, and taking care of the effective care of the patients, especially in healthcare. So it's very important. The dynamics of the team are important. We have our personalities are important. It's I If you were talking about my team, so I'm gonna shout out. They're all there. I know that they've texted me, my nurses there, and all the members of my team, my mentees too, and my mentors too. So, the team dynamics, we all work together. We have different personalities, we are different ways of working, but we all have one mission. And that one mission is to take care of our patients. And that one mission is to deliver our best possible care to make everyday life easier for our patients. So when you have one common mission, and even though you have different personalities and you different ways of working too, you're working for this one mission, you fit along well. And this is one of the important points in establishing the neuroendocrine tumor centers too. And it's not just my immediate team as well. We had similar relationship with some of the other specialties too. Surgical oncology, my surgeons are always on my speed dial, and they always are available. They pick up, and hence vice versa. We are always available too. We have very good relationships to our interventional radiology colleagues too, whether it's after hours, before hours. We try to make sure that we, deliver the best care by communication. And we have then our neuroendocrine tumor board as well, who meet once a month, and we discuss all our neuroendocrine tumor patients, all experts, all expertise. They are there, and we have a very collegial relationship. We get along well, and we have just one common mission, and that is to take care of our patients. However, I don't not it's not the last, that's the least. I do want to include my research team too. I think I may have forgot to mention them too. They are also an integral part of our team, because this is how we open clinical trials and help our patients too.
Gotcha. Thank you so much. And definitely big shout out to the team back at home, back in Tucson and elsewhere. Next question comes from Mara. Is it true that once you surpass, sorry, I lost it. There it is. Is it true that once you surpass 5 years of nets, eventually the prognosis improves?
Um, it's still an area of ongoing knowledge developing about the long-term survivals. This is how I usually put it. The longer you are from the date of your diagnosis, the lesser are the chances of the cancer or the tumor coming back. Now, there are always exceptions to this rule. The exceptions never make the rule, or exceptions never break the rule. It happens. And again, going back to the biology of the tumor, the patient characteristic, the tumor was given. So 5 years is generally used as safe cutoff, but more recently we have started to even observe patients longer too, because we've had seen some patients whose cancers have come back even after 5 years. So the field is all, trying to move away from this strict 5 year cutoff and trying to include patients up to, a 10-year mark over the instances. But again, this depends on, the patient characteristics, the disease biology, how aggressive was it, and what kind of treatment was given, and was it any treatment given afterwards or not. So all these factors also do play a role in determining how often or how long we will be following the patients.
Gotcha. Thank you. Thanks, Mara, for your question. Next question comes from Shane, the star of our recent documentary. Hey, Shane. Does shrinkage from PRRT have any correlation to the aggressiveness of the tumor?
So this is what we were. This is a very good question. Thank you, Shane. So we have recently learned this from last year, the NETTER-2 trial that came out. That trial did include the grade 3 patients, which are well differentiated neuroendocrine tumor patients, especially from the pancreas. That was those patients were not included in the NETTER-1 trial. So we did see that the response rates tend to be a lot better in those. Now, this aggressiveness is what Shane mentioned is as a layman term. Now, poorly differentiated neuroendocrine carcinomas are very aggressive, and we don't use as standard of care like lutetium dotatate. We don't recommend using this lutetium dotatate or PRRT treatment in those patients. So for grade 3, well differentiated or a higher degree of grade 2 patients, we tend to see more effectiveness of PRRT, but this is an evolving field. We still are waiting for the final results from NETTER-2 and the survival and quality of life results too. So we'll eventually see how this all pans out.
Got it. Thank you, Shane. Next question from Samantha. Hey, Samantha. My mom passed away from pancreatic adenocarcinoma. Sorry to hear that, Samantha. I was told that her type was not familial. I was diagnosed then with PNET. No one else in my family has experienced either disease that I am aware of. The question is, should I be concerned about my siblings or my children as far as increased risk? And this is a popular question.
And it's actually something that I get asked a lot too. So thank you, Samantha, for this question. Not all neuroendocrine tumors are familial or hereditary. There are certain syndromes we worry about that can be passed on in a fashion from the parents to offsprings and have siblings too. So I think again, it depends on the presentation. You do have to take into account that our knowledge about genetics is evolving. It is growing every year. Things we know now were not in our knowledge 10 years ago. So this is a very evolving field. I think in order to just talk specific about you and your family members, it will be always good to have a consultation, discuss it with your provider, and if there are any confusions, have a consultation with the geneticist to just understand that is there any role of new genes, or do you even qualify for genetic testing?
Got it. Thank you. You mentioned, Dr. Arshad, some of the syndromes. Do you mind expanding on what those syndromes are that you look at from this perspective?
So some of the syndromes are like the multiple endocrine neoplasias, like type 1. There are men type 2 as well. Those are some of the common ones that I come across too. That has a constellation of like a combination of other tumors too. Patients can have like thyroid problems or parathyroid issues, which raises the calcium levels. They can have, in addition to pancreatic neuroendocrine tumors, they can have pituitary, which is a gland that's present at the base of our brain. They can have tumors in those. So when somebody presents like situation like that, it just becomes very important that we refer them to the clinical geneticist. For the sporadic tissues, for the sporadic people, that one family member got diagnosed with pancreatic, neuroendocrine tumors, usually the recommendation is not to get genetic testing unless in the right clinical context. So in confusing cases, always good to have a consultation with the geneticist.
Thank you so much. Next question comes from Sasheen, who had the question about complications in SI nets earlier. She's now in recovery, and when barely able to eat or drink, what is the priority to get in? Protein drinks, water. She can't handle food right now, so what would be that top priority?
I think after it seems like I think the context would be nice. I don't know if Sachin provided some information before that. Did she have the surgery, and in what context, what type of treatment has she received before? So in general, recovering from any treatment, the number one goal usually is to maintain the weight. We don't want patients to lose weight. I do recommend generally eating healthier is better. Like, doesn't matter what type of diet it is. But I think even before we choose it, the number one priority is getting the calories in to maintain the weight. Whether you can do it by, eating protein, or definitely we need protein. We need a balanced diet, of sure. There's no doubt about that. But also we want to have intake of enough calories. So in Sachin's case, that I think it will be important to see that why is she not able to eat? Are there issues with swallowing, or is she not able to digest the food, which can commonly happen in patients with pancreatic neuroendocrine tumors?
Yeah, just as I got her previous question up, just as a reminder, she had the abscess and small bowel leakage and healing from the emergency lap, only to develop another abdominal infection and abscess without any signs of a leak.
Yeah, that can be a very challenging situation to be in. If you're having problems with infection, there are very few limited options available that can help, with this, because solid food may aggravate some of her symptoms. So I think whatever form that she can take in, oral route is the best route. But of course, there are alternatives that are always available in this. Just needs to be discussed with her provider that what kind of alternative options, if needed, will be there to help support her nutrition.
Got it. Thank you, Sasheen. And I will say, like, there are a lot of great protein drinks out there now. That field is growing, and a lot of them that are lactose free, which helps a lot of people as well, because that's a problem too. So a lot of great options that can hopefully help. Folks, we've got about 15 minutes. We're going to keep pushing forward, so keep those questions in. We'll try to get to them all. Next one comes from Shane. What does lymph node conglomerate mean when seen on a scan?
It's lymph node conglomerate is just a fancy word, I call it. Conglomerate means like a bunch of this. When 2 or 3 lymph nodes are separately and getting bigger or enlarging, sometimes they're in close proximity, or they're very close connection to each other, that they fuse into each other, join into each other, and it just turns into a big lump of cells. And sometimes, if you've been following the tumors or the lymph nodes, you're not able to appreciate the separate borders of those lymph nodes. So in those, to describe some of those tumors, they sometimes mention this big lump of cells that's sitting over there that was initially separate, now just turned into a conglomerate.
Got it. Thanks, Shane. Let me know if that makes sense, or if you have a follow-up question. Melinda says there's a fairly new MEN genetic mutation called MEN4. I have it and my daughter has it. I was told at this time there are only 100 cases in the world. I was unfamiliar with that.
This is fairly new information for me too. Thank you very much, Melinda, for sharing that. As I was mentioning, that our knowledge about neuroendocrine tumors is, every day it's evolving, especially the knowledge about genetics too. So thank you very much for sharing this information. I don't think there was a specific question related to that concept.
No, just more piggybacking on us talking about the MEN syndromes earlier. But yeah, that was definitely news to me. So I appreciate you sharing that, Melinda. Yeah, I mean, honestly, that's part of the appeal of the show, is, as I said earlier, just the sharing of personal experiences through this. So next question: can I do my last PRRT if my platelets are 70, or should I wait 1 or 2 months so the platelets will improve?
I think again, this would be a question to discuss with your nuclear medicine specialist too. It depends on how aggressive the tumor is, and what is the disease burden, and each institutions have separate criteria too when they decide to modify the dose or the schedule of the PRRT. I think this will be a good discussion to have, taking into account all the other factors too, about the last treatment. It will be important to know that has the other prior cycles caused any similar problems or not. Something that she should absolutely discuss with her nuclear medicine specialist.
Got it. Thank you, Mauro. Dr. Arshad, a question for you. I know obviously each case of this disease is unique, but I think I mentioned this to you at the beginning of or before we started recording. Even though the population here on the show and in the net space are very well educated, I always like to consider the newly diagnosed patient. So, what would be your first piece of advice for someone who just this week was diagnosed with a neuroendocrine tumor?
I think this is something, the responsibility heavily lies on the care teams, and I think for the community too. We're still dealing with the fact that a lot of people are out there confused whether they are benign tumors or not really the real cancers, or do we actually need to worry about. So I think it's really important that this conversation has to be had with the provider, just to explain the disease biology. Just the fact that getting diagnosed with neuroendocrine tumors can cause a lot of psychological and emotional impact on the patients. Even though we can, there are treatments available. I think the conversation with the provider is absolutely important, to know how aggressive the cancer actually is. It is a grade 1, grade 2, grade 3, whether the treatments are needed or not needed, what stage is it? Is it curable, non-curable? And once we'll figure this all out and discuss all the treatment, I think it's important from the support from the community too, to discuss the resources, the financial impact of the things, and more importantly, the patient experiences. Sometimes they also help to make give confidence to some of the other patients too, like sharing your stories on forums like this.
Absolutely.
I do would like to add, Rain, on this too, that now we're in a lot better position than what we were before. 10 years ago, choices were limited, the trials were limited, and some of these community resources were limited too. So I think we are heading in the right direction. Still a long way to go.
Thank you. Question from someone named Lisa. Hey, Lisa, can you discuss cabozantinib and what your approach is to dosing? What's your preferred starting dose, and what tips or tricks might you have to deal with managing side effects?
So cabozantinib is one of the most novel treatments that have been included into the landscape of, or in other words, I said the arsenal of treatment for neuroendocrine tumors. And it's not an easy drug to take. It is a tyrosine kinase inhibitors and can have some of the serious side effects. I think discussing with your provider and the provider experience with this also matters a lot. But this drug cabozantinib has been around for the last several years, even though in the not in the neuroendocrine space. So different people have different ways of handling the side effects. Of course, it depends on the side of and type of side effects too. That are you having issues with just? I would mention one of the side effects, that hand-foot syndrome. Sometimes one of the side effects that deal. So we can handle this by either dose reduction, holding the dose, saying what grade or what severity that side effect is, making sure we provide the supportive treatments, and then let the patient recover from those side effects and either dose reduce it or modify, in other words, like sometimes giving a little break. So there's no right or wrong answer here how to modify the doses. We have been provided by the FDA package insert that we can go like a 20 milligrams dose reductions, and sometimes those are not even helpful too. It depends on then the level of expertise that I have even tried some of the very low doses of medication too that have proven or effective or helpful for our patients.
Got it. Thank you so much. Dun, dun, dun. Thanks for your question, Lisa. I have a question, Dr. Arshad, about DIPNEC. Are you comfortable with anything in the lung net space?
So I can maybe briefly talk about it, but it's just I think what exactly is the question
Yeah,
related?
I'll tee it up and we'll see. This is from Lori. Is DIPNEC cancerous or benign, and how fast do they grow? I have it.
So it's still an area of like somewhat of an evolving field that we're trying to know more. I think if I remember, it's pulmonary neuroendocrine cell hyperplasia. Um, um, I personally don't come across a lot of those because since I'm a GI, a neuroendocrine tumor specialist, and some of those patients they do end up with our thoracic oncology colleagues. It's not a one size fit for all. Some of them can grow faster, but it's important that should be discussed with your providers and have the pathology be reviewed by some pathology experts who have some experience of looking at those.
Got it. Thank you, folks. We've got a few more minutes left, so if you have questions, send them in now before we wrap up our time with Dr. Arshad. Dr. Arshad, you had mentioned earlier in the show that you had something that you wanted to say, a certain message. Would you like to deliver that while we still have people on the call?
Absolutely. So, it's almost an hour. The time
Yeah, I
passes
told
by.
you it went by fast.
All right. So as we're wrapping up on this, some of the sentiments I've already echoed earlier that managing neuroendocrine tumors is really a team effort. And whether it's medical oncology, surgical oncology, nuclear medicine, endocrinology, intervention radiology, our nursing teams, our nutrition teams, supportive care, our community partners, our partners like Neuroendocrine Cancer Foundation, we each bring this special expertise, and that helps us shape the journey of the care. And last but not the least, the most important member of this team is the patients. They are our patients. So I always say this whenever you're making a treatment related decision, please make sure that we listen to our patients. Please make sure we understand what do they want, what do they understand, what matters to them too. And a lot of times the answer does lies when we just listen to our patients. So every decision, whether it's about surgery, whether it's about systemic treatment, chemotherapy treatment, or local regional treatment, or even with surveillance too. It's just important to consider what matters the most to our patients. Their values, their quality of life, what are their goals? What do they want? And if we do center our care on those priorities, we not only improve outcomes, we build trust, we build partnership, the same trust and partnership we talked about at the beginning. And it's the future of this care. It's just not only in discovering new treatments or running clinical trials and having advanced technologies, but it's also continue to listen and collaborate among ourselves, collaborate with our patients, collaborate with our teams, and place our patient's voice in the heart of every plan. So people who know me is just like they remember this. I mean, I've shared this before. This isn't the first time I'm doing it. I like to, end all of this by our famous Canadian physician, Dr. William Osler's quote that a good physician treats the disease, but a great physician treats the patient.
I love that so much, and I appreciate you sharing that. People start to peel off here in the last few minutes. I wanted to make sure everybody heard that, and I just wanted to share something too along that along the lines of what you said. Something that I hear many of the doctors on the show say, which at first was a little like, I didn't doubt it, but I had never heard it before, was that we learn just as much from the patients as they learn from us in this format. And you're nodding your head in agreement. And so many other doctors and specialists and experts have echoed that same sentiment. And I think, when I talk about the strength of this community, that reciprocal relationship is a perfect example of that representation of the strength of that community. And I think it's really important to get across is it's not what historically we may have thought is like, I am the provider and what I say is goes, and you follow that path. It is absolutely this relationship, this collaboration, and I think that is really a beautiful thing, but also is what helps us get to the answers of so many of these questions, is actually collaborating and working together, and that's with your whole comprehensive team as well as the patient and their team. So yeah, even Rob in the comments said, thank you for the honest conversation. I think it's so important, and I really appreciate you saying that. It means a lot to me, and I know it means a lot to the patients. Well, we've got another question about PRRT. I think we still got some time. Jim says PRRT and alpha PRRT are relatively new treatments. If the somatostatin receptors have been studied, which of those react best with PRRT treatments?
I think this is still an emerging field, so I think it's still a little bit earlier. And I say so far, the jury is out there. This is what I was saying, but jury is out for this. But we currently know that the alpha ones are better. We have some preliminary evidence. We have some preliminary trials that alpha particles or alpha treatments have outperformed the lutetium or like the Lutathera treatments. But a lot of those bigger studies, like I said, taking into account, does those treatments help the patients live longer? Does those treatments affect the quality of life in a way that they can still have, an active life or meet the goals they want to meet? A lot of that information is still pending in the form of clinical trials. So scientifically, or based on the initial phase 1 and some phase 2 studies, we have proven that the efficacy, the effectiveness of alpha particles is more than the traditional Lutathera treatments. But the long-term studies, the long-term effects, how they are compared to Lutathera, some of those trials are still in the process of ongoing, and they're ongoing. They're in the process of making, and will be in the works. You will see that in the next few years.
Got it. Well, thank you for that. And that is our show for today. Dr. Arshad, thank you so much for being here for the first time. I appreciate you very much and your time.
Thank you very much for everyone, and thank you very much, Rain, and thank you very much for Neuroendocrine Cancer Foundation for having me, and thank you very much for all our patients, like I said, who've joined across the country, across the globe. It is truly an honor to speak to you and answer your questions, and thank you very much for sharing your stories.
Absolutely. David says in the comments, thank you very much for a great program. Very helpful, Dr. Arshad. That is exactly what we're here to do, David. We appreciate you being in attendance. As always, folks at home, I hope this program helped answer some of your questions and give you some information. I'll reiterate one more time. You can always reach out to ncf.net/support line for questions. In the meantime, we put that link in the comments. As I said, we will be back in 2 weeks on the 18th. And in the meantime, appreciate you all being here as always. My name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on